We are back with our series of CMEs on Beyond the Pause, Redefining Women's Health in Midlife in the month of October, the World Menopause Awareness Month. This is our 5th CME, and we have more CMEs coming on different platforms. We have been supported by Cox Central, and KNH in bringing forth these CMEs. I thank Cox Central for today's platform and the entire team involved in making this possible. Hormone replacement therapy is the most effective way of increasing the quality of life of postmenopausal women. It also primarily relieves effects of hyperestrogenism, that is vasomotor, genitourinary, neurological, and psychomotor symptoms. Despite the benefit of hormone replacement therapy, unscheduled and/or unwanted uterine bleeding decreases patient compliance. And thus, we need to hash this out. We need to address abnormal bleeding for women on HRT. There is actually very little that has been published on this topic, and very few guidelines that are not very concrete, and there's a lot of ongoing research. And our knee-jerk reaction when this happens, when we get a patient who is bleeding, is to stop the therapy. And that's why we have Dr. Winnie Mwebia to tell us more on this topic. Dr. Winnie Mwebia is an obstetrician and gynecologist with 14 years of clinical practice, mainly in public health facilities in Embu County, Kenya. She holds a Master of Medicine in Obstetrics and Gynecology from the University of Nairobi in 2018 and an MSc in Global Health from the University of Oxford, UK, 2023. She recently transitioned into research mainly focused in maternal and newborn health. Currently, she works as a research scientist at Cambridge Center for Global Health Research in Kisumu. She serves as the clinical and technical lead of the Pregnancy Risk and Infant Measurement Alliance, the PRISMA project, a multi-country 3-year cohort. She is also a peer reviewer for PLOS One, an interdisciplinary open access journal committed to advancing sound scientific research and promoting transparency, equity, and accessibility in scientific publishing. Her interest in menopause health lies within the broader continuum of women's healthcare. Through education, research, and practice, she hopes to advance healthy aging for women beyond the reproductive years, ensuring that care extends well beyond maternal health. Her goal is to promote and support access to best practice healthcare that support women throughout all life stages, empowering them to thrive in every phase of their lives. Dr. Winnie, thank you for presenting today, and the platform is yours.
Thank you, Dr. Hafsa, and thank you to the audience for joining the series this evening. So the topic for today is abnormal bleeding of women on hormone replacement therapy. So the objectives are to provide a brief review of menopause and hormone replacement therapy, and then highlight the causes of abnormal bleeding, uterine bleeding, in peri and post-menopause, and then evaluate the risk factors for abnormal bleeding in women on HRT. And then we're going to also evaluate endometrial cancer risk associated with the HRT, and determine when to investigate and schedule bleeding in HRT users and clinical assessment, as well as discuss management strategies, and finally highlight local research gaps and areas of exploration. So by way of introduction, hormone replacement therapy, or what is also called menopausal hormonotherapy, is rising. There's a rising demand due to the rising population of aging women. So it is estimated that by the year 2050, actually half of global population will be women beyond the age of 65. And also the average expectant life of women in sub-Saharan Africa, and especially East Africa, is estimated at around 62 years. And this highlights the need to start thinking critically on how to improve care for this aging population. And also we now have clearer risk benefits of evidence of hormonal replacement therapy. And this is after the Women's Health Initiative study and the Million Women studies that initially provided a bit of controversial evidence of substantial risk, but post that was around the year early 2002, 2003. But since then, this evidence has been looked at in more detail, and it has been found that the benefit profile for HRT, particularly for women below the age of 60 and if initiated within 10 years of menopause, confers substantial benefit. And then also, due to enhanced knowledge and empowerment and autonomy of women, they are opting more and more for HRT. And now we have wider availability and a range of options available. So abnormal bleeding on HRT is quite substantial, affects about 8 in 10 women on HRT within 1 year of use, and it interferes significantly with health and quality of life, and contributes to therapy discontinuation in about 30% of users, and may also signal underlying pathology. But this is a call to be alert, not to be alarmed. So comprehensive and individualized assessment is key to management of abnormal bleeding on HRT, putting into consideration the individual risk factors, both modifiable and unmodifiable, and HRT associated risks. So an overview of menopause. So menopause, this has been done in the previous series, but we'll just run through briefly. So it's the natural and permanent cessation of menses that is associated with the non-pathologic estrogen deficiency. However, we also have pathologic estrogen deficiency states, such as premature ovarian insufficiency, as well as surgical menopause. Could I kindly request anyone who is unmuted to mute? Yes, thank you so much. So menopause is a point in the continuum of women life stages for women along the natural aging process. So it's a process that if we are granted long enough life, all the ladies here will have to go through it at some point. It marks the end of reproductive years, marked by decline in ovarian and actually complete cessation of ovarian function much later in menopause, as well as reduction of production of sex steroids from the ovaries, and that is essentially mainly estrogen and progesterone. So the menopausal transition is as a result of a decline in ovarian function, as I've stated, and ends at final menstrual period. Then the perimenopause phase itself includes the menopausal transition and goes up to 1 year after the final menstrual period, and on average takes about 4 years. So menopausal symptoms vary in nature and as well as severity. So some women will experience very minimal symptoms or of mild nature, others on the severe end. So about 80% of women will be affected by one or another kind of menopausal symptoms, on average lasting about 7 years. And about a third of postmenopausal or menopausal women will get long-term symptoms. And these symptoms have a significant health and quality of life impact. So just to review the stages of reproductive aging, and this is borrowed from the stages of reproductive aging workshops, STRO +10 20, that was released in 2011. So it's +10 because the first stage, or rather the first compilation of stages was released 10 years before, that's around the year 2001. And then with further research and evidence generation of the reproductive transition, including the definition and assessment of hormonal profile in this range, then we came to STRO +10 in 2011. So the stages are essentially 3, that is the reproductive stage, and then the menopausal stage, transition stage, and then the postmenopause stage. And this is made up of 7 phases. So the reproductive phase comprises of 4 phases. And this is the early, at the beginning, followed at the initial stage after menarche, then followed by the peak reproductive age, and then the late reproductive age that comes in very close to the menopausal transition. And as you transition towards the menopausal transition phase and postmenopause, there's a gradual and progressive decline of ovarian function. And that is why in the late phase, there's regularity of menstrual cycle really begins to change and becomes a bit irregular. And then in the early menopausal transition phase, this is where the irregularity becomes really quite prominent, going on to the late phase. And so as you can see, the perimenopause phase includes both the early transition phase and the late, and then goes into 1 year after the final menstrual period. In terms of the hormone profile, in the menopausal transition phase, there's a reduction in both anti-Mullerian hormone, inhibin, but mainly a reduction of estradiol. And then and FSH begins to rise, and then by the end of the menopausal transition, then the FSH level rises significantly to levels above 25 international units per liter. So the symptoms will usually begin to set in the late menopausal transition, and the most common symptoms will be the vasomotor symptoms. These will include the hot flashes, and they are very distinct in that they begin in the upper body and they come in waves. And then in the early postmenopausal phase as well, the vasomotor symptoms are quite prominent, and actually this is the phase when they are most prominent. And then as you transition into the late post-menopause phase, that is when we have increasing symptoms of urogenital atrophy, and this brings about sexual dysfunction in terms of dyspareunia, as well as urinary symptoms with frequency, nocturia, and recurrent UTIs. Yeah, so this is basically what we've talked about. And then, so coming to the indications of HRT in menopause. So HRT basically provides exogenous hormones, either estrogen only, or in combination with progesterone. But the main hormone that is replaced is actually estrogen, and progesterone is given in women who still have intact uteruses, and this is to reduce the risk of developing endometrial cancer. So some of the absolute indications is vasomotor that have a significant impact in the quality of life, and then in osteoporosis prevention or management, especially when other treatments are not tolerated. And this is particularly for younger women, either women with premature ovarian failure or who have surgical menopause. And the other absolute indication would be, premature ovarian insufficiency, and there's benefit in prevention of ensuing cardiovascular risk, osteoporosis, as well as the associated cognitive decline due to estrogen depletion. And then the other indication is genitourinary syndrome of menopause. And this is especially if it has significant impact on the quality of life. And for these particular local preparations are preferable. So for relative indications, this would include any mild symptoms and sexual disorders in menopause, and then in cardiovascular disease prevention in younger women within 10 years of menopause or before the age of 60. All right, so the contraindications include patients with breast cancer, and this is particularly for systemic preparations because they confer the highest risk. And then those with any past history of robotic events, and this is especially for systemic preparations, and those with uncontrolled hypertension or liver disease. So uncontrolled hypertension would be worsened by estrogen supplementation, and is also an additive risk factor for endometrial cancer. For liver disease, this is because estrogen is mainly metabolized in the liver. And if there is a compromise in terms of liver function, then that affects the estrogen clearance and would place the patient or the woman at risk of heightened risks. So we say that this is a repeat. So for the relative contraindications, any family history of breast cancer or migraines, especially migraines with aura, and for these transdermal preparations would be consideration. All right, so we've basically gone through this, why we need to give exogenous hormones, mainly the estrogen and progesterone, for the relief of menopausal symptoms. But it's also good to note that despite the advancement, there's quite a wide variety of options available, but we still have access inequity in the sense that even in the high-income countries, white women will tend to have HRT prescribed compared with Asians or Blacks. So this is data from NHS this year, actually. So there's, you can see that disparity in access. And yes, I've mentioned that the use of hormonal therapy dropped significantly, especially around the year 2010, 2011, after the release of results from the World Health Initiative studies. So the initiation of HRT should be highly individualized. So should it be given in the first place, and what formulation? When should it be given and how? So balancing the risks versus benefits, and also access issues, what is available, what is affordable, and preference. in terms of, what route of administration would the woman prefer, and this is to optimize adherence. And then one principle involves, giving the lowest effective dose at the beginning and adjustment accordingly. So before we go to the abnormal, I'd like to quickly review the normal physiology of uterine bleeding. And so the endometrium is essentially made up of two layers. There's the basal layer and then the functional layer. And it's quite responsive, highly responsive to sex hormones. And this is mainly estradiol and progesterone. So along the menstrual cycle, in the early phase of the cycle, from around the time of menstruation and the ending of the menses, moving on, there's a steady rise of circulating estrogen up to around mid-cycle when ovulation occurs. And with estrogen, with high estrogen in circulation, the response of the endometrium is proliferative. And also we have some vascular changes. And with the estrogen effect, the vessels are relatively immature and with minimal smooth muscle. And that means the ability to contract and vasoconstrict is really minimal. And then after ovulation, there's a surge in progesterone levels, which is produced by the corpus luteum. And this goes up to end of the cycle. And the changes in response to progesterone are mainly secretory in nature. And this involves, growth and proliferation of and maturation of glands, and also maturation of the arteries. And this gives them the capacity to constrict. So at the end of the cycle, if there's no implantation, then there's a progesterone withdrawal as the corpus luteum, degenerates, and that sudden withdrawal of progesterone is what causes a slowing of the endometrium and ensuing menses. So it's critical to understand this cycle, so to also understand the different regimens of HRT and the abnormal nature of bleeding with hormonal replacement therapy. So with that in mind, the hormone types, so as I said previously, there are different preparations. So some of them are either estrogen only or combined estrogen and progesterone. And then, combined estrogen and progesterone preparations, as well as other newer molecules, such as the selective tissue estrogenic activity regulator, and the main one is tibolone. So for estrogen only, we have oral transdermal formulations, vaginal preparations in form of either cream, pessaries ring, and for combined estrogen progesterone, we either have oral preparations and or transdermal or intrauterine device. And in terms of the schedule, so for estrogen only preparations, they're given daily and in continuous, and often they are tricycled. And what this means is after 3 months of continuous administration, then progesterone is given every 3 months, after every 3 months, and that is to lower the risk of endometrial hyperplasia and subsequent development of endometrial cancer. So the dosage options for estrogen-only preparations, we have the ultra-low doses that would be about 0.5 milligrams, and the low dose, which would be about 1 milligram formulation, and the medium dose, 2 milligrams, and high dose of 3 milligrams. For transdermal preparations, the dose will range from 25 to 100 micrograms. So for the combined estrogen progesterone therapies, there are two schedules, and one schedule is what we call sequential HRT. So sequential HRT is where we start with the estrogen preparation only, and then at the end you combine with progesterone formulations for about 10 to 14 days. And so for this one, it really tries to mimic the normal menstrual cycle. And the other formulation or the other schedule regimen is the continuous combined HRT. And for the continuous combined HRT, so the both estrogen and progesterone will be taken continuously. All right, so for Tibolone, the dosage option or the administration schedule is usually it's given continuously with a dose of range of about 2.5 to 2.5 milligrams. The standard dose would be about 2.5 milligrams. So coming to bleeding during HRT, we'll go through the definitions of different types of bleeding, and this is adapted from the same working group that worked on the FIGO abnormal uterine bleeding classification. So bleeding is basically either any expected or unexpected bleed that a woman would use with more than one pad a day. And spotting is also expected or unexpected bleed, where a woman would use, either one pad or no pad at all. And then unscheduled bleeding is any bleeding or spotting that occurs before the end of a progestogen sequence in the combined sequential HRT. So for scheduled bleed, it's any bleed or spotting that occurs after the end of the progesterone sequence in the combined sequential hormonal therapy. So the combined sequential, as we said, you will initially begin with estrogen, and then the last phase will include progesterone administration. And this mimics the normal cycle. And therefore, for this preparation, a woman is expected to have some bleeding, which is almost like normal menstrual bleeding. And for early scheduled bleeding, it's any bleed or spotting that with onset before the end of the progesterone or the progestogen sequence in combined sequential hormonal therapy. So the bleeding patterns with the HRT, so the normal pattern will depend on the age or HRT type. So younger women will tend to have a more regular cycle as opposed to older women. And for the HRT types, oral preparations tend to have, a more stable concentration of estrogen and bioavailability in serum, and therefore they tend to have a more regular cycle as opposed to if it's given transdermally or local administration. The other thing is also sequential HRT that mimics the normal menstrual cycle tends to give more normal pattern as opposed to the continuous combined HRT. So for sequential HRT, yes, as I said, it gives a more predictable cyclical bleeding that lasts about 3 days to maximum of a week. And if a woman has persistent or heavy withdrawal bleeding, then that is not normal. And the prevalence of normal bleeding with sequential HRT within the first year of use will be about a range of 8 to 40%. And with the continuous combined HRT, amenorrhea is expected within 6 months of starting. And in perimenopausal bleeding, irregular bleed may occur due to residual ovarian activity because they're still producing a bit of estrogen, and so they may have a bit more of unscheduled bleeding. So the incidence or of abnormal bleeding with this group of women on continuous combined HRT is much higher compared with those with sequential HRT, with a range of up to 77% in the first year of use. And lower doses of both hormones and especially estradiol will lead to less unscheduled bleeding. And then in terms, if you compare the different types of estrogen and combinations, the combination of conjugated estrogen and medroxyprogesterone acetate will have a higher risk of unscheduled bleeding compared with preparations that have a combination of estradiol and norepinephrine. So looking particularly at bleeding with women with continuous combined HRT, the overall amenorrhea rate within by the end of the first 12 months of administration is again a wide range of 6 to 90%. And the discontinuation of therapy due to bleeding would be up to 30%. That means 3 out of 10 women will most likely drop out. So this unscheduled bleeding is highest, is more commonest in the first 6 months, and it's less with the oral preparations compared with transdermal preparations. And this is because of the, the steady bioavailability and of estrogen in circulation. And if a woman develops bleeding in the early treatment cycles, then it's also predictive of bleeding in subsequent cycles. And then also the HRT timing will determine whether, or rather will have an influence on the probability of bleeding, unscheduled bleeding. And this is commoner in early cycles versus later cycles, and there's usually a gradual decline after the first 2-3 cycles, and the biggest decline observed after 6 months. And then it is higher with perimenopausal women compared with postmenopausal women, and we've said it's because of the residual ovarian function. That would mean there's a bit of estrogen, endogenous estrogen production. And then in terms of age, younger women are at a higher risk than older women. And then in terms of hormonal therapy preparations, this again differs. So looking at the causes of abnormal uterine bleeding in general by FIGO classification, using the palm coin mnemonic. So we have structural causes and non-structural causes. And for the structural causes, this is anything, abnormal within the uterus itself, that is endometrium, or within the myometrium. This includes polyps, adenomyosis, myomas, or malignancies. And then structural causes, things like coagulopathies, ovarian dysfunction, especially in anovulation. And then we also have endometrial causes, such as endometrial hyperplasia, iatrogenic, either use of by IUCDs or any other medication that would interfere with the normal menstruation. And then there's also another class that is not well defined, otherwise unclassified. So in terms of abnormal uterine bleeding, especially in this phase of life, in the menopause, perimenopausal age, malignancy would be the greatest concern. And as I mentioned earlier, bleeding would be a call for vigilance rather than a cause of panic. And this is because, why vigilance? Because good majority of endometrial cancer cases, especially the type 1 endometrial cancer that is estrogen dependent, will present with abnormal bleeding. But then less than 10% of women with postmenopausal bleeding will have endometrial cancer. So that is why we have to balance between the vigilance, but not causing undue panic. And then also looking at the variation in survival rates when endometrial cancer is diagnosed early at about 95%, 5-year survival rate for early endometrial cancer versus quite a low 5-year survival rate with extrauterine spread. So the approach to clinical evaluation, Dr. Kanyi took us through a very comprehensive talk on clinical evaluation of postmenopause, of menopausal and postmenopausal women in general. And this, even for women with abnormal bleeding, would follow the same approach. So would start with a comprehensive history and mainly evaluating on the risk of endometrial cancer, as well as to establish other causes of abnormal bleeding, and then have a comprehensive examination and investigate the cause. So for the investigation, we need to know who should be investigated, when, and how. And one of the cornerstone of investigation for abnormal bleeding for both premenopausal and postmenopausal, and more so for these women on HRT, is endometrial evaluation. And then we'll also have counseling, referral, and follow-up considerations. For the history, first of all, have a very comprehensive bleeding history that entails what's the frequency, how frequent is this bleeding, how long does it last, how regular is it, does it come when scheduled, when on HRT or out of schedule, and the volume as well. So the volume will determine, the urgency of addressing issues and also complementary management. The onset, when did this bleeding begin? Is it acute onset, or it's something that has been going on for some time? And what is the timing? The timing in the sense of when they are taking the HRT hormones preparations. Is it at the beginning? Is it at the phase? Is it just any time? And what are the triggers of bleeding, if any? Especially if there's contact bleeding, then that would point more towards local causes, like within the cervix, or within the vaginal lining itself. So it's also good to evaluate the associated symptoms, such as pelvic pain, is there dyspareunia, is there discharge, and any other bleeding history, as these will help us evaluate what the cause would be. Is it related to the HRT or its other associated pathology? And is it within the reproductive system? Is it within the uterus, cervix, or it could even be coming from the bladder or the bowel? We've had instances where patients have been sent for gynae review with report of bleeding, only to find out that it was maybe hematuria or even hematochezia. And then also look at the, ask about the HRT history, what preparation, the dosing, duration, and even, and very key is compliance. Because if HRT is administered in an unscheduled or irregular way, then that means the woman will not sustain stable dose, stable concentration of especially estrogen, and this may lead to unscheduled bleeding. And then also establish what other medication they are taking, like anticoagulants. Of course, they put the patient at risk of abnormal bleeding. Anticonvulsants like phenytoin, carbamazepine would induce liver enzymes and lower the bioavailability of estradiol because of faster clearance. And then some antibiotics, especially anti-TBs, also induce liver enzymes and would lead to the same. And then a careful obsgyne history, and this is to evaluate either, past pathology or even establish the risk of endometrial cancer. Then look at the medical history. Is the patient diabetic? Do they have liver disease that would interfere with the estrogen metabolism? Are they hypertensive? Also, this would increase the risk of endometrial cancer. And hereditary cancers in the family, whether there's any cancer of endometrial malignancies, gut malignancies, polyposis, familial hereditary polyposis, which would also elevate the risk of having endometrial cancer, thyroid malignancies, and then also social history, things like smoking, alcohol intake would also elevate the risk of endometrial cancer. So looking at the specific risks of endometrial cancer in women on HRT, so there are those that are HRT independent. That means they're not at all related to HRT or would modify the risk of endometrial cancer development while on HRT. And one of the key factors or risk factors is obesity. So obesity actually increases the risk of endometrial cancer by about 40%, and BMI of more than 40 increases this risk by 10 times. And then age is also an independent risk factor with a sharp increase noted after the age of 55 and peaking at around the age of 70 to 74. And then any high estrogen states, especially past history of polycystic ovarian syndrome, diabetes, and stable liver disease, and some hereditary syndromes. So there's a syndrome called Cowden syndrome and Lynch syndrome. So Cowden syndrome is one of those that belong to the hereditary polyposis syndrome, group of diseases, and would put a woman at risk of having endometrial cancer, and it's also associated with other cancers such as thyroid cancer, colon cancer, and all, and then Lynch syndrome as well, which is associated with endometrial cancer, of ovarian, as well as cancers of the GIT. And then we have the HRT dependent risk factors that we've talked about, the regimen type, and then the progestin type that is used in the combined regimens. And of note is that the levonorgestrel IUD confers the greatest protection. That means the least risk, then followed by norethicirone, and then the norethicirone and medroxyprogesterone acetate. These are the synthetic progestins, and then followed by micronized progestins. So the other HRT dependent risks are, we've talked about the duration of HRT. So the longer the duration, the higher the risk and the presence or absence of unscheduled bleeding. So going deeper into the specific HRT regimens, so for continuous combined HRT, and this we've said that this is HRT that combines both progestin, the progestogen and estradiol, and is given continuously without a break, is actually confers us some protection against endometrial cancer, and this is especially for women with a high BMI. And we know adiposity is one of the high estrogen states, and that is why the risk of endometrial cancer in high BMI women would be higher, and therefore giving this continuous combined HRT, especially with the progestin component, then confers a bit some benefits. And for regimens that have an ultra low dose of estrogen to standard dose, and say that's about 0.5 milligrams to 1 milligram, and then with proportional progestogen have less than 1% risk. And for sequential HRT, where begin the first phase with estrogen preparation only, and then add progestin in the last 10 to 14 days, the risk is in users is equivalent to risk in non-users, especially if the progestogen is taken for at least 10 to 12 days per month. So what this means is women on this regimen will not have a higher risk of endometrial cancer. And if the progestogen component is taken for less than 10 days, the risk increases about threefold after 6 months. So you see why it would be important or beneficial to women to give for more than 10 days. And the risk of endometrial cancer will triple after 5 years of sequential HRT, with a relative risk of about almost 3. Yeah, it essentially triples. And this is why there's a recommendation that for younger women, because the preferred regimen for younger women is sequential HRT, it should be given for about 5 years, or depending on when it's initiated, or up to the age of 54 years, whichever comes first. And this is to reduce this risk. So for types that are tricycled, so this would be estrogen only preparation that will be given continuously, and then after 3 months progestogen administered. So this will have a higher incidence of hyperplasia and cancer compared to the monthly regimens. And this is because of that long duration of unopposed estrogen exposure. And then for purely unopposed estrogen preparation with no added progestogen, then the risk increases substantially. And the risk after about 3 years will be 62% higher, or 11 times higher, close to 12 times actually, by the end of 2 years. And for micronized progesterone, with a standard dose of about 200 to 300 milligrams, it is protective if it is used for 12 to 14 days per month. and but it is not known the safety beyond 5 years is quite uncertain. So higher doses would be recommended if the woman is on the high dose estrogen regimen, and the high dose is the 300 milligrams, or if unscheduled bleeding occurs. So for the levonorgestrel IUD users, it's quite protective with estrogen with up to high dose formulations. So high dose estrogen formulations, and this this benefit is conferred up to 5 years of use. So after 5 years of use, it's uncertain whether there's still a substantial benefit, as well as if the IUD is mispositioned. So it's not very certain whether the risk is, the benefit is still substantial. And then when transitioning from sequential HRT to continuous combined HRT, this should be done after 5 years or maximum, or by the age of 54, whichever comes first, to lower the risk that is associated with sequential HRT regimens. And for women, perimenopausal women who do not mind becoming amenorrheic, this can actually be started much earlier and cancel the patient on the likelihood of having unscheduled bleeding. So the risk in terms of presence or absence of unscheduled bleeding on HRT is substantial. So this indicates when there is unscheduled bleeding, it indicates that we've not achieved effective suppression of endometrial proliferation. And if this happens, then evaluate the risk level and then adjust therapy accordingly, either by increasing the progestogen dose or reducing the estrogen component, if not on the lowest dose, and evaluate the possibility of IUD placement, and then closely monitor the woman and investigate, especially with regard to endometrial thickening, as well as endometrial sampling for histopathology. So for any form of hormonal therapy, especially the combined regimens, whether it is sequential or continuous combined, at more than 5 years of use, there's no extra risk of endometrial cancer. And the same applies to use at about 10 years, by about 10 years. So the baseline risk of endometrial cancer for women in the age of 50 to 59 years is about 2 per 1,000 cases. And in this group, there's no elevated risk for any combined hormonal therapies. Then for estrogen-only hormonal therapy, there's a substantial increase in risk by about 3 times after the first 5 years of use, and about the same after 10 years of use in the age group of 50 to 69 years. And sorry, there's a bit of a mix here. Apologies for that. So the risk is elevated if after 5 years of use by about threefold, and after about 10 years of use, the risk is elevated 9-fold in the same age group of women between 50 to 69 years. So in summary, the major risk factors would be BMI of especially more than 40, and genetics, especially women with Lynch or Cowden syndrome, and women on estrogen-only HRT preparations with intact uterus. And for those women on tricycle HRT, which is continuous administration of estradiol, estrogen preparations, and then with administration of progestin every 3 months. If this is used continuously for more than 12 months, then there's a high risk of endometrial cancer, and prolonged use more than 5 years, and especially for women who started at around 45 years or more. So that's high risk, and more than 12 months use of noreldisterone or medroxyprogesterone acetate for less than 10 days a month, and for the micronized preparations for less than 12 days a month. So we said the ideal duration for these preparations would be at least 14 days, 12 to 14 days for the synthetic preparations, and then a minimum of 12 days for the micronized progestins. So minor risk factors, as I've indicated, a BMI of more than 30 but less than 40, history of diabetes or anovulatory cycles in polycystic ovarian syndrome, and women on estrogen-only preparations, where they've used for more than 3 months, but less than 6 months, and with an intact uterus. So generally, it's not recommended to have estrogen-only HRT for prolonged durations for these women with no co-administration of progestin, either as an IUD or oral preparations. And then we've talked about recycling. So the risk will be minor if this has been used for more than 6 months, but less than 12 months, that is less than a year. And for the sequential HRT, if it is used for more than 6 months, but less than 12 months, using noreldisterone, the synthetic compounds for less than 10 days, and micronized progestins for less than 12 days. So in terms of assessment for abnormal bleeding on HRT, the key assessment, as we've alluded to, is endometrial assessment. And of course, this will be guided by the history, what's the most likely cause of this bleeding. But nevertheless, endometrial assessment is very key, and ideally through transvaginal scan. So for women who have uniform endometrium, that means there are no irregularities, no cystic changes, and thickness of less than 4 millimeters on continuous combined HRT or less than 7 millimeters for sequential HRT, the action would be to adjust the HRT dosage for 6 months and then reassess sooner if the bleeding persists despite dose adjustment. And then for women with thickened endometrium above more than 4 millimeters in continuous combined preparations or more than 7 millimeters in sequential HRT, there's an indication for further assessment in terms of endometrial sampling. And then for those women where there's incomplete endometrial visualization, but they still bleeding, unscheduled bleeding, and ruled out other causes, local causes from the cervix, and it's clearly uterine bleeding, then this calls for further endometrial assessment. And then for women who are asymptomatic, So there's no bleeding at all. Maybe they were just coming in for just a routine check, but the endometrial thickness is equal or more than 10 millimeters, then this calls for endometrial sampling. And then for women with just normal endometrium, but with persistent bleeding, despite dose adjustments and despite maybe even change of regimen, then this calls for further evaluation. And then for women who bleed while on tamoxifen, regardless of the endometrial thickness, this calls for endometrial sampling. And this is because tamoxifen already increases the risk of endometrial cancer. So these should be, so these women we should have a lower threshold of investigating. And the reasons underpinning these decisions is endometrial thickness of less than 4 millimeters basically has a 99% negative predictive value for endometrial cancer. So meaning the 9 or close to all women with this endometrial thickness will actually not have cancer. The false negative rate will be very low. So we say tamoxifen, elevates the risk of endometrial cancer by up to 7 times, and that's why we need to have quite a low threshold for endometrial sampling, regardless of the endometrial thickness. And then other basic investigations, just full blood count, thyroid hormone assessment, cervical screening, depending on the age of the woman, and cervical screening status if they've not had a scheduled coagulation profile, and pregnancy test. So talking of a pregnancy test, perimenopausal women still have a chance of becoming pregnant. So in the range of 45 to around 49 years, I think there's still a chance of conception, spontaneous conception, of about, I think 8% or thereabout. And the other thing is that quite a majority of pregnancies around this age will end up with pregnancy loss, about 8 out of 10. So it's key to have to begin with PDT especially in women where menopause has not been established. They did not have the last menstrual period. And also, just to note, HRT does not confer contraceptive, is not a contraceptive option, so to speak. So the methods of endometrial sampling, so essentially 3, so ranging from the pipelle biopsy, and the advantage of pipelle biopsy is that it's a minimally invasive procedure, really an office procedure with no anesthesia required, and quite a high diagnostic accuracy of about 81% and a low false negative rate. But the con of it is that it may miss focal lesions and may end up with insufficient sampling up to 31% cases. So for hysteroscopy, this is considered the gold standard. And the biggest pro of this is the direct ability to directly visualize the endometrium and have a see and treat approach. If there's a specific pathology that can be treated in the same sitting, if there's a polyp, if the submucosal fibroids then can be removed in the same sitting. And then it also reduces the need for repeat procedures. However, this can be quite invasive, requiring some theater and anesthesia, although it is possible to do under spinal anesthesia, and the high cost of setup, and especially in our setting, quite limited access, and concerns of iatrogenic malignant spread. However, studies and evidence around this is quite inconsistent, so not very well established, but guidelines do recommend to profile patients, those who are at a high risk of having a malignancy, depending on transvaginal scan findings, then you may not want to perform hysteroscopy. Quite high sensitivity and specificity. And then the other option is dilatation and curettage, which has been quite phased out in many settings, but it's an alternative when hysteroscopy is unavailable. And the other advantage is the ability to collect more sample volume compared with the Pipel sampling. So for management considerations for abnormal bleeding with HRT, so the general principles is first of all, to review compliance of HRT intake, especially if they're taking oral preparations or they have on no transdermal preparations that they need to change regularly. And they can have correct use with either use of reminders or simpler regimen. And for the other principle is looking at individual risk factors, especially the modifiable ones, in terms of things like obesity, lifestyle changes to reduce weight. And this would, substantially reduce risk, especially after the initial investigation, and there's no indication or evidence of malignancy. And then the other key consideration or principle is to optimize the management of comorbidities, especially, diabetes, if there's liver disease, to optimize the management, and also discuss contraceptive needs, especially for the younger women. And consider a levonorgestrel IUD as an option, especially for high-risk women. And this is because levonorgestrel, as we've seen, confers the highest protection and really does not require any action from the woman. Once it's placed, there's a regular release of progesterone in the endometrium. So for women on continuous combined HRT, when switching from sequential HRT to continuous combined, because you've said for sequential, you should use in the shortest time possible, maximum about 5 years, within 5 years of use. So it is recommended to offer a washout period. So basically a washout period is giving the woman a break for about 1 month. And what this does is it allows for the endometrium, which had already accumulated, to slough off and begin afresh in a new cycle. However, within this washout period, there could be a risk of breakthrough, worsened bleeding. The other thing that would help in continuous combined HRT is dose adjustment by increasing the progestin dose. So, or offering levonorgestrel IUD. And there's also an option of short-term progestin. So like give a medroxyprogesterone acetate for about 3 months and then reassess. And then switching the routes of administration is also a consideration, and can switch from transdermal to oral. And this is dependent on the risk profile of the patient, or add a progestin to the transdermal preparation. Then for women on sequential HRT, it would be good to synchronize the cycle. And this means to mimic the normal menstrual cycle as much as possible, and it is easier to use progestin for the last 14 days. So we said essentially it is best to use for between 10 for at least more than 10 days, 10 to 12 days. But for easy remembrance and to mimic the normal menstrual cycle, then can do 14 days. And then for younger women, you can consider addition of COCs. And the other consideration is a progestin adjustment by increasing the dose or using vaginal preparations of micronized progesterone, or completely change the progestin type. So we said that the micronized preparations will actually have more breakthrough bleeding, so it can change from micronized to synthetic preparations. So surgical management is really like the last option, and dependent on the underlying pathology and severity of the bleeding. So we have these there are fibroids or polyps, then the right surgical procedure, and then just a note that endometrial ablation would not be recommended, and this is because in the subsequent follow-up of the woman, it's quite difficult to assess the endometrium after endometrial ablation. It would either not be visible or have irregularities, and that would a bit confuse the interpretation a bit. And hysterectomy would be a last option if conservative management fails or the quality of life is severely affected, and there's high risk of endometrial cancer with continued, and they still need for continued therapy to deal with the menopausal symptoms, especially the vasomotor symptoms, which can be quite problematic. So we've partially talked about this. So when to refer the woman, especially if there's bleeding that has persisted for more than 6 months and there's heavy bleeding, but referral here now would mean to a gynecologist, and especially someone who is quite experienced with hormonal therapy, management of patients on hormonal replacement therapy. And then for established cancer, after histopathology, referral to oncology colleagues, and then if there are any multidisciplinary management needs, like optimizing diabetes control or liver disease, psychiatry, if there are comorbidities, especially if a woman has significant mood disorder, and either worsened by HRT, the abnormal bleeding, or considering withdrawing in view of abnormal bleeding. And orthopedics colleagues for cases of risk of osteoporosis, and then follow-up considerations within 6 months, if 6 weeks rather, if bleeding persists after dose adjustment, and this would call for repeat ultrasound or even moving ahead with endometrial biopsy. Follow-up would be 3 to 6 months, either after dose adjustment or treatment changes, or as needed in acute or prolonged bleeding or recurrent bleeding, bleeding that had stopped previously, then has come back, then would need evaluation on a need basis. So just to wrap up with the trends in menopausal hormone replacement therapy related research. So this is a recent paper of 2022 that looked at publications within MHT related research, and you can see research from Africa was quite minimal, less than 1%. So vast majority is conducted in the high-income countries, and the top countries are, US, Italy, UK, China, and the other listed countries. And then we had 13 institutions that had more than 200 publications, and 9 out of the 13 were from the United States. And the focus areas were around obstetrics and, gynae conditions. So we really did not go into the granular details. Oncology, the risk of cancers, in endocrinology and metabolism. And then the top 10 authors, again, the United States led, and followed by Italy. So this poses the question, even as we administer hormonal therapy in our local context, are we just shooting in the dark? Is the current practice within our local context backed by evidence? And the reason to ask this question is, contexts really vary significantly. First of all, we do not have much data on menopause, both qualitative, quantitative, in terms of, prevalence, what is the age of onset, what are the women perceptions of menopause and the associated symptoms. Colleagues here will recall a discussion that ensued during the last conference about on HRT, on administration of HRT. So what are the perceptions of the women locally? What are the symptoms associated with menopause locally, and what is the impact on quality of life? So the other useful research would be, what is, in terms of HRT, is it even accessible in the first place? What is the availability? Is it affordable to the common woman? Because you'll agree, even locally, we have quite wide disparity in terms of access. Is it acceptable? And what is the unmet need? And then what is the safety of menopausal hormonal therapy within our local context? So demographics locally and in the US, on the high income countries where we have most of these data is and evidence is generated, varies significantly in terms of, even age at onset of menopause. So there's evidence that in the Black population, menopause sets in much earlier. So does it mean that women, if we're to start on women on HRT, then they're likely to be on it for much longer? And then education status is also very key for the woman to understand, first of all, even simple compliance and risk factors and when to seek medical care. Also, healthcare capacity within our local context. Are we able to monitor women on HRT effectively? What is the interaction of HRT with the locally prevalent health conditions? And this, looking at infectious disease, there's emerging evidence around malaria infection and risk of hypertension and other cardiovascular complications later in life because of the endothelial damage. And there's also, in our context, we also have a substantial burden of HIV. So how does HIV disease and ART also interact with HRT? So we also have, NCDs, especially quite a high burden of breast cancer in our context. So that is why we really need to have local research to support practice of menopausal hormonal therapy within our context. So take-home messages are, as we've said, that menopause symptoms can cause quite substantial health and quality of life impairment. And HRT can offer significant relief, but with careful risk-benefit evaluation because of the associated risks, especially looking at abnormal bleeding. And when there's abnormal bleeding, it can lead to therapy discontinuation. And, these would really not confer the intended benefit of HRT for the woman, as well as compromise the quality of life. So careful assessment, including the risk of endometrial cancer, is key. So we've also noted that local research is lacking to guide optimal HRT therapy. As of now, we rely on data that has been generated and evidence that has been generated, particularly in high-income tech settings. So this is an opportunity for care optimization for us to optimize the care of women during menopause and aging. So as we strive to advance women's health, there's need for interventions that will restore but not compromise the well-being of women. So that's the end of the session. I'll open up for question and answer session, and also invite my colleagues who have been running this series to take up some of the questions.
Thank you very much, Dr. Winnie, for that explicit presentation full of knowledge. Before we proceed on to the questions, I'd like to request all of you to fill in the feedback form to help us improve our presentations and to know where we need to elaborate further. The link is in the chat box. I have two questions in the chat box from Dr. Stefan Gingo. Over to you, Dr. Winnie and the panel. During tricycling, does it mean also that the estrogen is maintained during that period as well?
Thank you, Dr. Gingo. And yes, that would be so. Tricycling is, so the essence is just to add progestin component after 3 months of continuous estrogen administration. So this is part of one of the estrogen-only therapies that are given continuously.
Thank you, Doc. There's a question from Dr. Protas Nyongesa. Ideally, at what age should one end HRT?
So to attempt answering this question, the best would be to look at the risk profile. And from available data is that the risk of especially cardiovascular events and thrombosis will increase substantially after the age of 60. So going beyond the age of 60 would not really be recommended unless there's a very good reason as to why. And the other point I'll give is depending, this will also depend on whether the woman has an intact uterus or not. So the risk is substantially higher for women with intact uterus, particularly for endometrial cancer. And therefore considerations would be made for women who have undergone, hysterectomy. And then the third consideration would be the regimen used. So if it's sequential HRT, where give estrogen in the first phase and then the last phase give progestin, ideally you'd have to give it for maximum 5 years, or maximum up to the age of 54, whichever comes first, or else switch the regimen. And then The second question is, would you put obese women on HRT, especially those with abdominal panniculus, knowing well that fat issues? Yeah, so for obese women, women with a BMI of more than 30, HRT would actually be protective of endometrial cancer, and especially in the as they age, because obesity in itself is a risk factor for endometrial cancer. But it's again an art of balancing. What other comorbidities do they have? Do they have a history of venous thromboembolism? Because then the risks would outweigh the benefits of administration. Any other question that I've missed out? And for my panel members, please feel free to chip in for additional comments.
Thank you, Dr. Winnie. There's a question from Dr. Rahab Chege. A patient 28-year-old with secondary amenorrhea, pregnancy test is negative, FSH is 35, TSH and prolactin are normal. She desires conception. How to proceed? Dr. Mushiri, would you like to give an input?
Yes, please, Dr. Mushiri. Dr. Mushiri gave the session on premature ovarian insufficiency, and she's also an infertility expert. So she says she can't unmute.
Okay, now I can unmute myself. Thanks, Hafsa. So okay, am I audible?
Yes.
Okay.
Yes.
All right. So from what I understood, a 38-year-old lady who's having irregular periods or they've disappeared and the FSH is high, sounds high, 35. The diagnostic first for whether she has had premature ovarian insufficiency would be another FSH 4 to 6 weeks from that last one, just to confirm. And then we need to know what the ovarian reserve is. And ovarian reserve markers are AMH, anti-Müllerian hormone, and the atrial follicular count. So until we sort of assess that, then we're not able to tell whether she can or cannot conceive. And that means with her own eggs. So it doesn't mean that she cannot conceive absolutely. She may be a good candidate for egg donation or then other, sort of other methods. But the point is an FSH is not diagnostic of capacity to conceive. I'd just like to add briefly to Protas's question. Ideally, what age should one end HRT therapy? The thinking now at the moment is you don't need to end it unless there's a risk. So like Winnie has alluded to, unless there's a reason for you to actually stop HRT. Remember, women have been having estrogen for nearly 50 years of their life. Well, if you talk whatever, 15 years to 50. It's not harmful to continue with keeping them and maintaining them on estrogen. So unless there's good indication or reason to actually stop it, some of these women get really bad withdrawal symptoms when you try. They go into actual menopause when you try to get them off the HRT, and you'll find a lot of them want to continue with it. My current highest patient is 85. She's still fine and she loves HRT. Thank you.
Yes, I also have patients who are hitting about 60 and are on HRT, and they're perfectly comfortable. We just need to be alert, and we need to be able to talk to them about turning up for their clinics and for their screenings. And they kind of do really well on HRT. You'd see them not really adding weight. Their functional capacity also remains quite good in terms of joint pains and in terms of the cardiometabolic functions. So I agree with Dr. Mushiri that presently that's the way the thought process is heading. Anybody else with any questions? I did see a hand somewhere. No questions? Thank you very much. Again, Dr. Winnie, for the wonderful presentation. Thank you to all those who took part in today's presentation. Thank you for your patience. And I would like to thank Coke Central for hosting us. And I'd like to call Dr. Mary Njoroge to close this session. Meet you next week, same time. Look out for our flyers, please, with more information on handling the midlife. Thank you. Dr. Mary Njoroge, please.
Am I audible?
No.
Sorry, I couldn't unmute before. Can you hear
Yes,
me?
you are. You are, Doc.
Oh, okay. So thank you, everybody, our presenters and the panelists and Dr. Hafsa. On behalf of COG Central, we really appreciate Dr. Mwebia for that comprehensive and very informative presentation and the challenge that you have thrown to the group about localizing the information that's out there. I'm sure we've all learned a lot about today's topic. So unless there's a burning issue, mine is once again to thank you all, including the participants, for your time and participation. And we can close the meeting. Have a good night. And thank you once again.
Thank you.
Thank you, everyone.